Let me know if I can start now.
Yes, please go ahead.
Right. So I'm presenting our paper today. It's Advanced Precision Healthcare AI-based Predictive Analytics in Chronic Disease Management. It's kind of a structured narrative review looking at how AI and predictive analytics are actually being used today to manage chronic diseases, what's working in real institutional deployments, and what field still needs to, or field areas in this particular specific subject needs to be solved. There's some issues, some concerns which are still evolving, and how AI is helping them resolve. So just a quick couple of slides on the profiles. Nand Kumar Raju, he's the Director of Software Engineering and AI in Optum United Health Group. I'm the co-author. I'm the digital transformation expert. I work with Cognitive Technology Solutions and also some additional roles as well. Let's go to the slide where we have about the subject. So let's start off with like framing the problem. Chronic diseases, basically they consist of the chronic pulmonary diseases, diabetes, cardiovascular diseases, cancer. They account for approximately 70% of the deaths worldwide. What makes them so hard to manage? It isn't like kind of it's a big failure, but it's an accumulation of smaller ones, where early signs which needs to be detected, they get missed, not mixed. And the treatment and adjustment that comes too late, medication choice that isn't quite optimized for that particular patient, that we call the customized or smart nursing management or smart disease management, the new term which is recently being utilized in the field of automation and optimizations. So that's the exactly kind of pattern recognition at scale problem AI is well suited for. So in this particular paper, what we have done is kind of created a structured narrative review, not really a research, but a narrative review, where we synthesized, identified problems where AI is well suited to resolve those problems. We also identify synthesized peer reviews and industry literatures from 2015 to 2025, not to catalog every technique, but to pull out what's actually working, what settings, and what exactly, why these issues are being being done, and how we are going to resolve them. Going to the next one, the methodology. So what we did to approach this review, we did three things. First, we mapped the dominant AI methods. We supervised the supervised and unsupervised machine learning, deep learning, natural learning, natural language processing, then the federated learning, explainable AI. Then we had like IoT-coupled models onto the specific chronic conditions where each has shown strongest empirical traction or transactions. Second thing which we pulled was, we pulled cross-cutting lessons from 5 widely cited institutional deployments. So these are those case studies which we have, which I'll touch base quickly on subsequent slides. So these are Cleveland Clinic, Kaiser Permanente, Mayo Clinic, NHS, and Mount Sinai. Thirdly, what we did was we synthesized all that information into a 4-layer framework, where we utilized data, AI processing, clinical use, and governance. Importantly, what we did was we just didn't write up the success stories. We extracted the information related to data privacy, algorithm biases, legacy and system integration, and even uneven access to get the same level of scrutiny for these slides, for these case studies, to eventually propose a synthesis framework for this. So let's start off with the 6 taxonomy methods which we mapped as part of this research review, as part of this paper review. So we have the supervised and unsupervised machine learning that are the workhorses for risk scoring and patient segmentations, especially in cardiovascular diseases and diabetes. We have the deep learning shines in pattern recognition over imaging and signals. For example, cancer screening, cardiac imaging, radiology imaging, etc. We have the NLP, or the natural language processing, in which lets system mine or extract unstructured clinical data notes, for example, for care coordination, for risk flagging, to identify those chronic disease, the onset of diseases, early stages. Third thing, we have the federated learning, which is increasingly important because it allows multi-site training, not really focusing on one concentrated study. So these multi-site training without a centralized patient data. This is critical for privacy sensitive cross-institution research, and this is especially important in healthcare setup, where PAI is very, very important, that we cannot really extract the data and then utilize it for experience or research. Third thing, which is being utilized across sectors, is the explainable AI models, where it matters where the clinicians or the regulators who evaluate the data, they need to understand why a model is made, not just what is predicted. So how a model is actually constructed and utilized, not just utilizing for prediction. Then we have the IoT-coupled models, bringing in continuous monitoring from wearables and sensors, which most of us we use in some way or the other. And it has shown real traction, specifically in the COPD, the chronic optimized pulmonary diseases and the diabetes management. The point of this particular slide is what that one method is best. It's the right method. It's not about the best method. It's the right method, which depends heavily on the conditions as well as the data which you use. So these are the 6 approaches which we discussed. Let's talk about those case studies, case examples where we talked about where we initially touched base upon. These are the 5 widely cited deployments. Most of the studies which we use for predictive analytics and utilization of AI, NLP, and LLM models for predictive analytics in healthcare, they touch base on these major studies. So first one is the Cleveland Clinic's cardiovascular risk reduction work. Then we have the Kaiser Permanente's population health and early intervention program. Mayo Clinic's AI-assisted diagnostics and imaging. Then we have the NHS, the UK's National Health Services, national scale predictive triage efforts. Mount Sinai, that's US-based deep learning work on enterprise health records data, the EHR data. These institutions, they started from a very different places. Different patient populations, different demographics, data infrastructure, the variation in data infrastructure. They have different regulatory environments. One is, some of them, they're based out of US and Europe. So they have their other HIPAA and GDPR related regulations and restrictions, data restrictions as well. But what's important is the cross-cutting lessons that was consistent. And the success is dependent less on how sophisticated the underlying models was, and it was much more on terms of the data quality, how well the tools fit into the existing clinical workflow, and whether there was a sustained institutional buy-in over the time, not just a successful pilot. So although because of the time constraint, I would have loved to go more detailed or deep into these specific case studies. It's an interesting read. So how we utilize the information and the case to come up with the synthesis contribution, kind of a 4-layer framework which we constructed. So layer 1 is a data, which is in terms of healthcare. It talks about the EHRs, imaging, genomics, wearable streams. Layer 2 is AI processing, where we utilize the data and then we process the information extracted from the data, where we have the actual machine learning, the deep learning, the natural language processing, and the federated training method, which we touched upon earlier in the previous slides. Layer 3 is the implementation, where we talk about the clinical use, how a model's outputs become a risk flag, a decision support prompt, kind of a care pathway, where a clinician or doctor or physician or the hospital setup, they actually act upon and utilize the outcome of that data. And the 4th layer is the governance, which is most important, one of the most important, and is often ignored as well, which talks about privacy protections, bias, auditing, regulatory compliance as well, which is kind of a framework which guides the other three layers in this part of the framework. The reason for this framework matters is that most of the deployments, they fail and they don't trace back to the AI method being wrong. They trace back to kind of a weak link in one of those other 3 layers or other 2 layers when we talk about the specifics. For example, a brilliant model which is trained on poor data quality will certainly fail. If there is a variation in terms of demographics, it certainly won't apply to one population, and utilizing the same machine learning and LLM models which we are being built on that particular data to other demographic population, specifically when we are talking about predictive analytics in healthcare. An example of a good, excellent clinic tool without a governance structure, as I talked about earlier, around it will eventually run into privacy or bias problems that undermines the trust, because it has to cater to each and every population as well. And then it has to pass through the regulation, the government or specific regional regulations for that particular region, for that particular demography as well. So that's the reason. That's why, like, thinking in these 4 layers, they help diagnose where a project is actually at risk. So not only it's a success factor, it also a identification. These 4-layer framework, it's an identification where we are able to flag those risks as well. Moving on to the next one. So what we did in this as part of our review was, uh, although it would have been easy to present this as kind of a straightforward success fact story, saying, okay, this is the problem statement, this is how we utilize the AI tools, and this is how we implement it, and this is the outcome of the paper. But what we did was, we wanted to take the implementation problem just as seriously as in terms of the challenges or the obstacles, if we call them. So we identified 4 obstacles that came up consistently in those the 6 models or the 6 setup framework which we initially discussed, related to data privacy, AI training, etc., etc. So these 4 obstacles, they come up consistently. They are the data privacy, the HIPAA and equivalent protection, GDPR, etc., genuinely constrain how training data can be aggregated and shared across the institutions, which is part of why we talked about the federated learning, which is gaining traction, because we don't really rely on one specific training data or training model, and then work upon that. We also touch upon algorithmic bias, where a model is trained on a non-representative population. We also talked about this a little bit earlier. It risks underserving exactly the patient, what needs the patient demography, who needs the most accurate predictions when it comes of identifying the indicators for the chronic disease management. We talk about the legacy system integration. Most healthcare systems, they are running on EHR infrastructure that was never designed with AI pipeline that we are talking about, like 10, 20, 30 years prior to when those EHR data structures, infrastructures was being envisaged or was being conceptualized. And that's the reason when we are talking about the the data structure which was built on legacy systems, and now we are trying to do the integration, which is often harder than building the model itself, which is one of the key concept or key you can say framework or building blocks of creating a you can say a valid or a perfect AI system which can utilize the existing legacy data infrastructure as well. The other thing, the fourth one, is about the uneven access. Institutions, they have like strong data infrastructure, they have capital, they keep pulling ahead, while underserved resources or the systems, specifically there where we have like not very solid infrastructure, they risk falling further behind, which has real quality implications. And these challenges are not specifically country A versus country B, or a continent A versus B. You're talking about, let's say, the North America versus Africa, but this is within the United States as well. We have pockets of underserved infrastructure in rural area, in the deep countryside, where or probably you can say the deep Midwest area, we do not have access to what they have on the coastal areas in the United States as well. Moving on to the next one. So why the algorithmic choices should follow the disease characters? Kind of a little more technical slide here, where we talk about more practically successful, useful sections of the paper. Looks why, okay, I have like 5 more minutes that quickly wind up. Why algorithmic choices should follow the disease character. It's not the other way around, because I'll take an example of cardiovascular diseases. Like, they tend to present as structures or longitudinal risk factor data. So we have like the supervised machines which are learning from risk scoring performance. They perform strongly here. The others, for example, the COPD, they generate continuous psychological data related to bronchitis, chronic pulmonary disease, etc., which is exactly where the IoT-coupled models, they kind of outperform the regular models, because they're able to catch those early sign of predictions or exacerbations. The other one is the imaging-based data, where we have the cancer detection, which utilizes the deep learning strength and picking up the visual patterns to identify or predict those onset of the diseases. The other one is the diabetes management, where they kind of blend with structures, clinical data, and also take into account the behavioral data. So the overall point, I'll just summarize quickly on this one, is there is kind of a no universal algorithm. It's very specific. The choice of the algorithm depends on the data as well as the disease, how it naturally generates. The next one is recommendations. We just identify like three major areas of recommendations based on everything which we synthesize. We landed off three sets of recommendations. Like for clinicians, it's a treat AI outputs as a decision support. So again, everywhere, most of the people who are in healthcare AI, healthcare technology, they say like specifically the decision making and the decision support for clinical and non-clinical data, it should be resting on a human or the human clinical judgment. It should not be relying entirely on a AI model. So these models are there to assist and augment the capability, not really replace the clinical judgment. So that's the reason, like if you can understand why it's kind of a flag the patient, then there is a limitations, then they talk about really small minor details which are fed into a decision making system. For technologists, we have to invest in data quality and governance infrastructure before we scale up in the model or make a more sophisticated model. So the more advanced the model is, the weaker data foundations will not help it. The lastly, for policymakers, this kind of aligns with the governance requirements in the four-layer structure. It should be built on regulatory framework that actually enables federated privacy preserving collaborations across the institutions rather than frameworks. So that kind of covers these three recommendations. Uh, I think so. This is the last or the previous last one slide. Quickly wind up. So where this field is most likely to move next. So when we look ahead, uh, we kind of identify the federated learning at scale. It's moving past small pilot studies into genuine production grade collaborations across institutions without ever centralized patient data. Then we have the IoT integrated continuous monitoring, which is becoming more of a standard input stream, not really a novelty where we can give an examples like the wearables, they feed directly into the chronic disease management. The devices, they are nowadays connected not specifically just to our cell phones or data, but even across multiple healthcare institutions, your primary physicians, your hospital network, your EHR, which is being managed. All these, they kind of interconnected. The third thing is the genomic informed precision medicine, where we are talking about the initially I touched upon the smart medicine, where we utilize predictive models which start incorporating genomic data into individualized risk and treatment at a level where the current EHR based approaches, they can't really make decisions on their own. So none of these, they are speculative as kind of is envisaged for a specific predictive model in healthcare disease management. These are all early versions, and all these three, they exist in literature, what we reviewed, but none of them, they can say, have reached the maturity, and then we cannot really with 100% confidence say they will be at that particular maturity level. My last slide here. So, and I'll end this presentation with saying, like, to bring this all together, the healthcare finding is that the AI-driven predictive analytics is, it's kind of, you can say, genuinely working in chronic disease management. They are striving to make it as specific, as accurate as possible. We had the five major institutions. They show like real gains in data, how it's actually working. We also identified the four-layer framework: data, AI processing, clinical use, and governance, which is often ignored. Then we have the team identified the risk components, and then we identified whether just specific model, a universal model is enough, but we identify like it's all specific to the data as well as for the specific disease as well. And I'll end this like the biggest single takeaway which we have this is the implementation discipline. So we are talking about handling the privacy bias, algorithmic bias, integration, and access, which is deliberately, which determines the outcomes as a model or the quality it produces, and sometimes more. So, end of the day, you can say precision healthcare or predictive healthcare decision making isn't just a specific monitoring problem. It's kind of a
Yes,
system.
I think you're right at the time. Fatin.
Yeah, yeah. So that was it. Yeah. Any questions? Yeah, that was the last slide I had.
Thank you. Yeah, let's move on to the next presentation. Who
Right.
is next
I'll stop
presenter?
sharing.
Thank you.
Thank you.
Thank you. Is it Khan? Mm, Khan or Nauman? Anyone is there? Human in the loop AI systems for financial decision intelligence.